and ECMO children at the Richmond, Virginia Hospital, and Chris Calaritis, and he's going to talk to us about aortic aneurysms in Virginia Hospital. Hello, Chris.
Καλό σας απόγευμα. Είμαστε από το Virginia τώρα το πρωί. Η Dr. Πρέβετζα από το UVA μια ώρα από εδώ και εμείς τώρα από το Richmond, Virginia. Σας ευχαριστώ για την πρόσκληση. Dr. Σωτήριος και Βίκη και Αθηνά και είσαστε very competent, and you're very lucky to have these two perfusionists at your hospital and at your center there, doctor. I will focus on the perfusion management of thoracoabdominal aneurysms using left heart bypass. It's a technique that I have been involved in my previous institution at McGill University. Και θα σας περιγράψω το technique εδώ και πώς το έχουμε κάνει specialize για το for this type of affliction. There's different types of techniques or that have to do with protecting the thoracoabdominal aortic area. There's the clamp and sew technique, which has a minimum of a 30-minute risk factor of paraplegia and acute renal failure of up to 30% with cerebral spinal fluid drainage and naloxone administration. There's the technique also of passive shunts for renal perfusion with a GOT shunt. There's the left heart bypass technique, which is the one that I'm going to focus on today. And number 4, which is a femoral cardiopulmonary bypass to reduce the afterload of the heart and to preserve the distal organ perfusion. They have different variations in management of heparin doses, of temperature, of dilution, but I will focus on the left heart bypass today. Let's just see here if I could change the slide. Left heart bypass in our clinical setting uses a centrifugal pump to deliver oxygenated blood drained from the left atrium into either the femoral artery or the distal aorta. Left heart bypass circuits deliver isothermic blood to organs at between 1500 to 2500 RPMs with a radial mean blood pressure of 80 to 90 millimeters of mercury. Selective renal perfusion is delivered through balloon perfusion catheters, and concerns about high shear stress rates that could cause hemolysis and coagulopathy when using high flow rates is definitely a concern about this technique. And the nasopharyngeal temperature is carefully monitored to avoid hypothermia-induced arrhythmia. So how do we prepare for these cases? This is the previous pump that we would use. We would use the Delphin Terumo centrifugal pump, but there are about 4 different centrifugal pumps that are on the market, and I'm sure that my colleagues in Greece and elsewhere in the world have access to many different types of centrifugal pumps, whether it's the Medtronic centrifugal pump, the Rotoflow, Mackay pump, the Spectrum pump, and other pumps such as the Centromag. You can see here the centrifugal head. We prime the circuit. It's an in and out circuit with no oxygenator. And obviously another very important part that we participate alongside the surgeon and anesthesiologist is the cannulas to make sure that we have the proper perfusion flows that we need with good drainage and to minimize the shear stress. We use malleable single-stage venous cannulas. We also have access to cannulas that are angle tip, and we prefer to use the IOPA arterial cannulas for arterial return. We have a chart that allows us to look at what cannulas we should use based on the patient's weight. Obviously, we have different patient sizes and different patient weights. So we cater or we adapt our circuit and our cannulas based on the requirements of the patient and the flows that we will need. Here on the left, you could see this is the cannulation in the left atrium, the left inferior pulmonary vein. Heparin is administered intravenously at a dose of 1 milligram per kilo. Patient's activated clotting time, ACT, is confirmed to be at least 280 seconds. The pericardium is reflected or open near the pulmonary veins, away from the phrenic nerve. And basically, I will defer the surgical technique, but my focus is going to be on the cannula. The left atrium is cannulated with a 24 French angle tip cannula. And it's connected to the venous drainage portion of the left heart bypass circuit. The reinfusion cannula is the arterial return line of the left heart bypass circuit is to establish an inflow or arterial return line. We usually use a 22 French angle tip cannula placed in either the distal descending thoracic aorta or the proximal abdominal aorta. The selection of the aortic cannulation site is aided by careful examination of the preoperative imaging. Basically, that will determine where we will cannulate. And that is basically the cannulation technique. So how do we conduct left heart bypass and the circuit? We have a flow chart. We have the hardware side. We have the inlet and the outlet, the tubing. Please note that this is oxygenated blood from the left side of the heart. Therefore, you have to leave enough blood into the preload side of the left heart to ensure that the heart pumps what is needed for the brain and the proximal side of the circulation, and you take just enough blood on the centrifugal side to the pump to deliver blood to the distal portion to protect the renal arteries and the distal portion of the body. So left heart bypass conduction. After the aorta is clamped, the left heart bypass flow is increased towards a target between usually 1.5 to 2.5 liters per minute to keep the patient's mean arterial pressure around 80 millimeters of mercury and distal aortic pressure of 60 to 70 millimeters of mercury. And obviously, I'm not going to go into the anesthesia techniques, but obviously you will need 2 arterial monitoring lines, one for the proximal side and one for the distal aortic pressure as well. The return line of the left heart bypass circuit has a Y connector attached that splits the pump return between the line going to the distal aortic cannula and another line leading to 2 9 French Pruitt balloon-tipped perfusion catheters for later delivery of selective visceral and renal perfusion. During this procedure, another portion of our responsibility as perfusionists is to make sure that we have blood collection device and a rapid infuser to make sure that we have that we're able to recuperate the blood that is going to come back from the surgical field while the surgeon is proceeding to open the aorta and repair the affected area. So this is an illustration of a modified cell saver system to enable rapid reinfusion of shed blood. There's a Y connector that is inserted into the cell saver line just distal to the collection reservoir, which provides microaggregate filtration to remove blood component materials, clots, and other debris. After back bleeding, the intercostal arteries are ligated. This ensures that the origin of each branch graft is positioned slightly inferior to the origin of the paired artery and thereby facilitates the formation of gentle curves in the branch grafts that help prevent the grafts from becoming kinked. The anastomosis between the aortic graft and the proximal aortic cuff is sewn. visceral and renal perfusion during the intercostal anastomosis. After the proximal anastomosis is completed, left heart bypass is stopped, and the distal aortic clamp and cannula are removed, and the aorta is opened longitudinally down to the aortic bifurcation. Left heart bypass during the proximal portion of the repair, followed by selective visceral perfusion with isothermic blood and cold crystalloid renal perfusion, while intercostal and visceral arteries are reattached. After the patch reimplantation of the intercostal arteries, the aortic cross clamp is moved down to the aortic graft, distal to the intercostal patch, thereby allowing reperfusion of the reimplanted intercostal arteries. The distal end of the aortic graft is trimmed to the appropriate length, and the distal anastomosis is performed. This is a collaborative effort with anesthesia and the surgeon and the cardiac surgeon. We monitor urine output, flow rate in visceral and renal perfusion at temperature, renal perfusion, and body temperature to ensure that we are not cooling the patient. After the graft has been de-aired and the anastomosis completed, the clamp is removed. Protamine sulfate is administered to reverse the heparin. Indigo carmine is also administered intravenously to assess the adequacy of renal perfusion. Ideally, blue dye should be visible in the urine within 20 minutes. I will not go into great detail about femoral bypass in the interest of time, but here are the steps for femoral bypass. We basically use femoral arterial and femoral venous cannulas. There's blood pressure control. There's also selective cold crystalloid renal perfusion. And there's adaptation of the circuit of the femoral bypass of the circuit to allow perfusion distally. And the worst case scenario is hypothermic circulatory arrest. And basically, we try to avoid hypothermic circulatory arrest as much as possible. Therefore, it all depends on what part of the aorta is affected by this by the aneurysm. But usually, we're able to with imaging, we're able to avoid hypothermic circulatory arrest. I'd like to thank the organizing committee for inviting me, and looking forward to participating in future sessions. It's a collaboration between the surgeon, the cardiac anesthesiologist, and the perfusionist. It's always a balance between flow for the brain and flow distally. This is a little bit of our ECMO program. This is our setup here for our ECMO team. Just want to highlight that. And this is our team here at Virginia Commonwealth University, Children's Hospital Richmond. And we do both adult and pediatric perfusionist at our institution. Thank you so much for the invitation. Ευχαριστώ πολύ.
Chris, thank you very much for your excellent presentation. It was very important to see all these techniques for left heart bypass that here in Greece, I don't know if in some center they try to perform this technique. I know that this technique was performed, as you said, Texas Heart Institute, that we were trained there with this exact type that you presented. And thank you very much again. Is there any questions from the audience? No? Thank you again, Chris.
Ευχαριστώ πολύ. Γεια σας.
Ευχαριστούμε πολύ.